Hi, testing. Checking to see if my audio and video is coming through. Great. It sounds like things are working. I would introduce myself. Thank you for joining me. I'm Dr. Michael Avery. The attempt here is to do a go live session on Facebook for question and answers with me, Dr. Avery. We're going to be discussing rheumatoid arthritis, a little introduction of myself. I am Dr. Michael Avery. I'm one of the rheumatologists with OSMS. I am one of the owners and partners of that particular practice, and meaning that our facility is all doctor owned. We own and manage the facility with the help of many, many wonderful employees and assistants who we can't function without. I wanted to give a little introduction about the topic of discussion for today. We will open it up for question and answers toward the latter part, and there's already been some questions that have been submitted that I'll address briefly. I wanted to give a little introduction. The topic is rheumatoid arthritis. We hear a lot of comments, or people have heard other people talk about, well, I've got arthritis. What does that mean exactly? There are many different forms of arthritis, and rheumatoid arthritis is a very unique form of arthritis. Let's talk with definitions first. Arthritis, arthro, that means joint. Itis is also Latin for inflammation. So anything that ends in itis implies inflammation. However, it's a little bit of a misnomer because often the term arthritis is applied to anything that has an indication of damage to the joint structure, and that'll be termed arthritis. You see an orthopedic surgeon and they see x-rays and say, yep, you've got arthritis. Well, they're referring to that there is damage visually with the structure of the joint, and that is technically arthritis. It doesn't always mean that there's inflammation of the joint, but there's damage. So it is also meant to indicate that there's damage to joint. In Rheumatoid arthritis is a unique form of rheumatoid arthritis, and it is what we call an autoimmune connective tissue disease. What that means is that, unlike, oh, I've lived a long time and my joints are wearing out and that cartilage is getting broken down. Cartilage is the lining of the joint that protects the joints where they come together. Let's use a knee, for instance. If that cartilage breaks down and we start to have the two bones rubbing together rather than having this nice smooth surface, well, we've got osteoarthritis. That's wear and tear. Over time, that's broken down, and now there's damage to the joint, and that might cause pain. And rheumatoid arthritis, rather than being a consequence of our age and having done damage to the joint, for instance, or wear and tear, there's a specific process in the body in which the immune system, which normally functions to fight infections and create inflammation when it's necessary to heal damaged parts, has inappropriately been programmed to attack and use the resources of the immune system. And there's a vast array of systems within the immune system, and a military is the analogy I use. You have the Army, Navy, Marines, and Air Force of your immune system, and there's hundreds and thousands of different soldiers within each system of of those groups of the immune system, and they're all programmed in rheumatoid arthritis to use their might and their resources to carry out the orders, which is what they believe to be, is to attack different tissues in the body that are, in this case of rheumatoid arthritis, the lining of the joints, called synovial tissue. And in so doing, that causes a tremendous amount of inflammation to the tissues, that then causes damage to the tissues, and that inflammatory substance in a bunch of the cells that are present in that substance and that inflammation goes on to cause accelerated damage to the bone tissue, the cartilage, the tendons, the ligaments. Not to mention, other branches of the immune system are being activated because, as far as the immune system knows, it's being programmed, or it has orders to carry out. It's being told, hey, we've got something wrong in the body. Let's attack it. Send in the Army, Navy, Marines, and Air Force of the immune system. Use all our resources and take care of it. Well, in doing so, there's also a lot of changes in the body in which different what are called cytokines. Those are chemical signals that activate different parts of the immune system are turned on and amplified. And a bunch of physiological changes, chemistry changes take place that lead people to feel sick, run down, tired, sometimes low-grade fevers. So the point is, rheumatoid arthritis is, and through the mechanism of autoimmune disease where the immune system is activated to attack, yes, the joints are involved, but it's really a whole body disease. There's a lot of chemical changes in the body that make people feel tired, fatigued. They might have low-grade fevers, and that's because all those systems of the immune system are activated. There are questions that are popping up right now, and I will get to those in just a moment here. So that's kind of the introduction to rheumatoid arthritis and how that's much different than wear and tear arthritis or typical what we call quote unquote arthritis, which is normally osteoarthritis. If we live long enough, we're all going to have some wear and tear. Just like our skin is going to wrinkle when we get older, our joints wear down and they're not as fine as they used to be. Just like if we took a hammer to a hinge on a door and banged it up, it's not going to work as well. And that's what happens naturally to our body over time, including the joints. And rheumatoid arthritis, it's a disease state in which the body is attacking itself, and that has a course of damage to the joints that's accelerated. And so we use medicines to turn that off. There are a lot of sophisticated ways that we can diagnose that condition. There are markers in the bloodstream, and that can help. But not all forms of rheumatoid arthritis have a nice, unique a marker in the bloodstream or an antibody test. But you can see other clues in the body to tell you that's happening, like elevated inflammation levels. When we examine a person, we know what we're looking for. We know which joints are typically involved, and we're seeing that they're swollen and enlarged, and how they describe those symptoms give us clues. So it's not one test that makes a diagnosis. It's the symptoms, the clinical features, what we see on exam, what we see on x-ray, the types of damage, all that collectively help us make a diagnosis. And sometimes we don't have the luxury of having a unique blood test in the classic form of rheumatoid arthritis that does exist, but there are forms that don't have that. At this time, I'm going to transition to question and answer. And there were a couple pre-submitted questions that I'm going to address briefly, and they may cover some of the topics or questions that you out there might have right now. My daughter just came in. Can you close the door, honey? So one of the questions that we had was, when you're on a treatment called a biologic, which is a type of medicine that is often used. You see those on TV commercials like Humira and Enbrel and so forth. Those are biologics. The question is, are occasional flares to be expected, or is complete disease control what we should expect? Well, that's a yes and no question, okay? So the goal in treating rheumatoid arthritis, in our ability in this day and age in 2020, is that we can achieve remission to the point that a person doesn't have activity, or they have very minimal activity. There are ways to judge that by what the patient's telling us, how much swollen joint tissue we see when we examine them, and measuring things in the bloodstream, looking at x-rays to see if there's progressive damage. That's how we judge it. So to answer this question, our goal is to achieve remission to where someone wouldn't have evidence of active disease. We're not always able to achieve that, and sometimes we have to switch medicines to obtain that. Biologics tend to be pretty effective for most people. There are the exceptions to that. Not everyone responds to a medicine, or they have complications with medicine, so we can't use those biologics for all people, or they're just not effective. The body finds a way to get around it. And to exert and carry out its orders, which is to attack the joints and do damage. And it finds another mechanism to carry that out. And that's what those medicines are doing, are targeting those mechanisms and signals to carry out that destruction. and we're trying to be clever and to block the main mechanisms. Biologics do that, and they target different mechanisms. For a lot of people, even when they're well controlled, they can have flare-ups. They can have periods of time when they did a lot of activity or other things that triggered or caused a little inflammation, but because their body's a little hypersensitive, even when they're on a biologic or rheumatoid arthritis medicine, they can still have flares. Flares are fairly common and typical, even in well-controlled individuals with rheumatoid arthritis, although they should be much less common and less severe in most cases. There's been another question that came through, and I'll intersperse some of the live questions with some of those that I got ahead of time. One of the questions was about donating plasma. Yes, we have not found a reason that it would be detrimental, at least with current medical science, that would be a concern. We don't see that necessarily these antibodies are transmitted that could then cause problems. It's a different story. So the answer is yes, most people with rheumatoid arthritis or who are on biologics even, they can still donate plasma and blood. Unless they're anemic or other issues might be a barrier to that. But at face value, that's not a limiter. There might be other things or anemia that might prevent it too. If you're already low on blood counts, they won't want you to donate. Another question is, are there any proven changes in your diet that can help with RA symptoms? That is a very common question that I get on a daily basis, at least 10 times a day. And the answer is, of course, dietary and other health strategies that are normally helpful for your health and all aspects of your health will help if you have rheumatoid arthritis. Now, to say that they are specifically disease modifying or they change the course of the disease, that unfortunately has not been proven. And they have attempted to evaluate that. It's just that studies with diet and measuring outcomes is very challenging because in a controlled experiment or trial using the scientific method, you want to control all variables. So you only want to have one or two things that you're changing and then measuring specific outcomes. And it's very challenging to control so that a person eats only one or two things and then you're measuring the outcomes and then maybe switch to something else. But in general, people with inflammatory conditions and autoimmune disease tend to do better if they are avoiding high sugar in their diet, and really the less the better. They seem to have less inflammatory flares. At least that seems to be the tendency. Some people will have more problems with intolerance to gluten or to milk products, dairy, and things like that, but that's very individualized. We do see and hear from our patients that they will identify things that are unique to them, that if they're eating a lot of a certain type of food, that can be flaring or triggering for them, and that's a little bit variable. It's not across the board. Generally eating cleaner. If a person, no matter even if they have rheumatoid arthritis or not, if a person stuck to more whole foods, meaning things that don't come in a processed box or hasn't been processed, if they're eating natural foods in their natural state, that's generally healthier. And it usually doesn't contain artificial colors and sweeteners and things that sometimes will stimulate an inflammatory response in the body. Good question. Omega-3 fatty acids and fish oil have shown some favorable response, although not conclusive or definitive, but some. Things like natural substances like turmeric has shown some merit in anti-inflammation, although in rheumatoid arthritis, really the jury's out. It hasn't been disease modifying or stopping the disease at all. But it symptomatically might be helpful. It's still not clear if that's safe in interaction with some of the other medicines we use, but it's probably safe. We just don't know enough about it because we haven't studied that specifically to know. Okay. Hopefully that answers the question about a diet. There's a blog on our website talking about anti-inflammatory diet if someone would be inclined to want to look that up a little further. one of the other questions that I had previously submitted was exercise. Absolutely. In rheumatoid arthritis, it's necessary. It does help. It actually alleviates symptoms because if you have a lot of congested joints that have a lot of swollen tissue, I always tell my patients it's like when you have that swollen tissue, it's like the tissue has absorbed fluid, water, and it's like a kitchen sponge. It soaks up a lot of fluid that collects around the joints. I'm using my hand as an example, and that takes up space. And that makes it so, boy, if you have a lot of packed sponge tissue around the joints, it's hard to move. Doing physical exercise, and by that I mean moving, not lifting weights, being aggressive, or jolting movements, which could damage joints that are inflamed, but moving does disperse that congestive swollen tissue and reduces it, and that helps your mobility and reduces pain by moving that congestive humors, the fluid and inflammatory substance out of the tissue. That does help. Exercise programs shouldn't be too aggressive as far as if you have knees involved or ankles and they're active. Then you want to be a little more cautious about things like impacting movements like jogging and things like that. Probably not a good idea. However, people with rheumatoid arthritis can do about every other exercise, even jogging, if their disease is controlled or they're considered to be in a remission state where there's not active attack and inflammation of those tissues at the moment. Then, and a lot of people do that and they resume prior exercise activities that they used to do, even sports activities in some cases. But you have to be very clear with your rheumatologist if that's felt to be in a remission state in which your joint tissues could handle that. Because if there's inflammation, there's going to be risk of damage from doing certain activities. But we definitely always want you to move and stay healthy, keep your heart healthy. Cardiovascular activity, as long as it's not hurting joints, is perfectly acceptable. A question that comes up a lot, which I did have, was about heredity. Is if I am diagnosed with rheumatoid arthritis, is my daughter or my son going to get that? No, not necessarily. Okay, the genetics of rheumatoid arthritis fall under the category of autoimmune disease, meaning that you don't specifically inherit a gene for rheumatoid arthritis and then now you've got it, you pass it on to your son or daughter and they've got it. What it is you inherit a certain series of genes that code or program, much like a computer program would, for the expression of how the immune system is going to function. So what we see in families is the tendency for any autoimmune diseases, and you can pass on that susceptibility in your genetic material so that, let's say, for instance, my mom has thyroid disease that's autoimmune, like Hashimoto's. Well, and then say my sister has Crohn's disease, which is an inflammatory autoimmune bowel disease. Well, we know that there's probably some increased genetic susceptibility for dysfunction of the programming of the immune system in those cases. And that series of genes, that programming genetic material can be passed on. And so there can be susceptibility or increased risk for even things like rheumatoid arthritis in offspring. It's not tremendous high risk, but we often see autoimmune diseases of all types cluster in families because they have shared genetic susceptibility, but it's not one autoimmune disease only passed on in Mendelian genetics, if you're familiar with that term. That's just not the way that works. Very good question. There is a genetic susceptibility and that can be passed on, but it's not a specific gene for a specific autoimmune disease like rheumatoid. Okay. So, another new question that we had come in. Does caffeine worsen rheumatoid arthritis? Not necessarily, no. But that goes back to the question we had about food and substances, for instance. Along that line, a lot of people who drink too much alcohol do find, and I should have mentioned that, we'll find that as something that's triggering for a lot of people. Because it's just harder. It disrupts the chemistry of the body, and if the body's already having some disrupted chemistry and function, that's going to shift things quite a bit more, and it's not going to be amenable for the body to be stable, especially when it's controlling inflammatory functions of the immune system. Alcohol has an effect. Caffeine, some people feel like it does have an effect, and so that's one that's a little more personal. And that's because we have some unique differences in our physiology, and that certainly is the case in rheumatoid arthritis. We understand that similar mechanisms and how it works, but it can manifest just slightly different for people, and there can be different triggers and flares. Caffeine, for some people that I see, they feel that it helps them, and gives them a little more energy because they're fatigued and things when that happens in RA. It's really personal, I would say, and dependent. So here's a common question. Along with diet, there is a very common question I get now in this new age of CBD, cannabidiols, marijuana, being more mainstream. And the question is CBD helpful for this? Symptomatically, it could be, yeah. It's not going to modify the disease. It's not going to impact autoimmune dysfunction. It's not going to turn off the switches. It's not the miracle that it's often touted to be in that regard in our world, okay? Symptomatically, for pain control, it does bind opioid receptors. Those are pain receptors. And so it's not inconceivable that it could be a pain inhibitor. The challenge is that CBD is now being widely manufactured by, anyone who wants to go into business. They have some mild regulation, but you really don't know what you're getting. You really don't know what the person who's selling it, if it's ingested or taken in through orally, if it's not contaminated with other things. It's not regulated by the FDA. It's not investigated or evaluated for safety. And by the person who's making it, that's not investigated. So you have to take their word for it and trust that it's legit and it has what they say is in it and nothing else. Topical is probably a little safer, in my opinion, just because the absorption in the bloodstream is not going to be detrimental, even if there were contaminants in most cases. But I do have people, and it's a mixed bag. I would say, seriously, probably 50% of people, and a lot of people do it and try it, and people that I see with rheumatoid arthritis try it, they feel that probably 50% say, yeah, I think it helps. I rub it on my knees or my hands and I think it helps. And I say, oh, great, I don't have any problem with that. And then equally about 50% of people say, yeah, I tried it, everyone's doing it, and I didn't find that it was helpful at all. So it could be helpful. There's some legitimate science that shows that it could be helpful as a pain reliever, and for other indications, but it's being widely studied. We're going to know a lot more about cannabidiols, CBD, and also other forms of cannabis and marijuana over time, and its medical merits. We still don't know a lot, and a lot of it's just speculation. And what we do know, we extrapolate that. Questions about how do we work together to manage the rheumatoid arthritis? Well, you want to get an excellent rheumatologist, and OSMS has excellent rheumatologists, and it is almost always, and I know this and I speak for my colleagues, it's a collaborative effort. We serve as the guide. We understand the disease. We know what's happening. We can give you some great insight about what you're experiencing and what that may be. We can look at the rest of your health to give guidance and say, look, you've got diabetes as well. You've got some kidney dysfunction. So we have to be careful about the selections of medicine we use. Here are the risks with any number of the options. And there are dozens of options in treating rheumatoid arthritis that all can be effective and achieve remission in this day and age. So we have a lot of options, more than we've ever had. It's individualized, though. You got to look at the health of the person that we're treating, the patient, you out there. We always want feedback. And again, speaking for my colleagues, it's not authoritarian medicine. We're telling you what we know works. We know what science has shown us can work for this disease. We try to We usually will want to educate you and tell you how the disease is working, but we do expect collaboration. The patient has every right to decide what therapy they use after we offer it. We're going to give guidance and say, I don't think that's a good option because X, Y, or Z. I think this other option would be good. And that's our job, is to educate you and tell you, what we're thinking. But ultimately, this is your body, and we're giving you the education. You make decisions. So people don't want to take medicine. That segues into a very good point. I hear a lot. There's a lot of fear about rheumatoid arthritis medicines, and I understand. I don't blame people. But the point I always emphasize to my patients is rheumatoid arthritis is a bad disease, and it's absolute. We know it doesn't just spontaneously go away, and if it does, it wasn't rheumatoid arthritis legitimately, okay? And we know the consequences of untreated rheumatoid arthritis, and expands beyond just the joints. It's a systemic disease, meaning the whole body's involved. Accelerated atherosclerosis, cardiovascular disease, heart and lung involvement have been seen. Kidney involvement through amyloidosis. It's widespread when it's not controlled. That high inflammation in the body is detrimental to the cardiovascular system and in the arteries of the body. And that's the leading cause of mortality in untreated rheumatoid arthritis, is premature cardiovascular disease, atherosclerosis, hardening and narrowing of the arteries of the heart, and heart attacks, strokes, and those type of things. So good question. Prednisone, there's a question about prednisone and how are flares managed. Yeah, often steroids are used for short term, but that has to be very careful. Steroids have high consequences, but it depends on the dose and how long you're using those doses. And so we're following that when we're giving recommendations. Bigger doses can be used for shorter periods of time and can get away with not having any problems. But doing that for too long, you're risking some adverse problems. Low doses can be used long term in a lot of cases without a lot of risk, but they cumulatively can lead to problems. Other treatments for flares is, we're having a lot of flares, rather than having to keep dole out steroids, which cumulatively could be risky if we're having to use a certain dose all the time, a higher dose. Then we might need to consider other options for treatment so we can have better stability of the disease overall, so we're not having as much flaring. And that's always the ultimate goal. Okay. There's a question about rheumatoid arthritis and osteoporosis. And the question is, do they go hand in hand? Not necessarily, but the risk for osteoporosis, and I'll define that. Osteoporosis is a condition, a disorder in which the bones become more brittle and more fragile and more amenable to fracture. There's lower bone density or thickness of the bone concentration, and most typically it will be in older women, naturally, when someone doesn't have rheumatoid arthritis. But anyone with a high inflammatory disease like rheumatoid arthritis, they're going to have higher risk for osteoporosis, because, again, we go back to that. This is a systemic disease. There are a lot of mechanisms and chemical changes that are activated in that autoimmune process, and that has a deleterious effect on bone reabsorption, and that leads to osteoporosis. And so it is an accelerated risk factor to have rheumatoid arthritis towards osteoporosis, but it's not a given you're going to have osteoporosis no matter what. Your risk is enhanced if you have rheumatoid arthritis and you're not having adequate treatment of that disease. So I think there was a new live question, and I would love to answer everyone's question. We'll try the best we can here. Here's the question. Do any vitamin supplements that help besides fish oil and turmeric? Well, we had talked about that. We talked about CBD and things for symptomatic relief. So this is another one that's not direct. It's not a one size fits all, but in certain circumstances, someone who's low in vitamin D, that can have an impact on how the immune system works. Vitamin D is used for a lot of processes in the body. So in regard to this question about vitamins and its impact, vitamin D could be in certain situations. That's not to say it's a panacea, like you give someone a lot of vitamin D and they don't have to take rheumatoid arthritis medicines. It does not stop rheumatoid arthritis, but it would enhance and help the body function better. And that can perhaps make the medications work a little better if the chemistry of the body is functioning well. Now, other supplements, unfortunately, no. And there have been extensive studies in supplemental vitamins and um, naturopathic substances, but to date, there's not convincing scientific proof that any of them have been disease modifying, that they stop or turn off the switches of rheumatoid arthritis or similar autoimmune diseases. They may be adjuncts, meaning they may be helpful, they may help in some way, but to achieve a remission state, the medications, this is factual, that we are prescribing have shown by reproducible studies and demonstration. You do experiments with individuals, and they've been proven to halt the disease process. So the medicines we prescribe have all shown that they can slow or stop the disease process, but that's always so individual if that cocktail medicine we're using is appropriate for the person we're treating. And sometimes you have to switch it up a bit. Supplements, unfortunately, haven't shown that, at least to my knowledge, but to be fair, they probably haven't been extensively studied in a controlled scientific environment as much as we would like, because there have to be monetary interest for people to study that and to pay for and fund the studies, and we just don't find that with supplements as much. There probably are some that would be helpful. I'm not aware, though, of them to date. And again, I had mentioned there had been studies on fish oil before, and it looked promising. And for some people, that does seem to help with their inflammatory process to some degree, but it's not modifying of the disease process, like stopping as a supplement or as a replacement to known entities like methotrexate and biologics and other medicines we use in rheumatoid arthritis, which have definitively proven we don't see progression of the joint damage, the inflammation turns off, those type of things with those things. We have not seen that with fish oil, with turmeric. Turmeric has had better evidence in support of relieving the arthritis pain in osteoarthritis. That's where the bulk of the studies in turmeric or curcumin have shown good evidence for anti-inflammation of that. And there's very little inflammation. There's lower grades of inflammation is from mechanical forces in osteoarthritis, and turmeric does help with that type of inflammation, but driven by the body internally from the immune system causing inflammatory response, turmeric has not been powerful or useful like in autoimmune disease. That's what I'm referring to. Okay. One of the other questions that we had that gets, and which I kind of alluded to, can you explain the protocol for a newly diagnosed patient? Well, it is kind of a journey for the patient and for the doctor working together. First, there needs to be proof that there's actually this entity of rheumatoid arthritis, and that's labs, X-ray, clinical examination, what the patient's telling you. And then sometimes there's a trial of an anti-inflammatory, like a low dose of a steroid. If we have a great response, that's a little more compelling that there's a deeply inflammatory process driving that pain process, more compelling for rheumatoid arthritis. Once that is the case, then there is an extensive discussion about the diagnosis and how that evolves, just like we're having today and like I've explained. And we start to talk extensively about the medications, the therapies. We always discuss the risks of those medicines. And there is no medicine without risk. There's no supplement. Fish oil, turmeric, there's nothing out there that a human can ingest that does not have risk. There are different humans that respond to substances differently. It doesn't matter how benign a substance is. There's someone in the world who has taken that substance and has had an allergic response or had some adverse problem, including foods, supplements, and certainly medicines. So all medicines have risks. We always have to weigh that risk with the benefit we expect, and we should expect that the benefit is going to far exceed the risk. And in most cases for rheumatoid arthritis, that is easily proven and accomplished, even though the medicines seem a little scary. The disease is always a lot worse unchecked, and that makes that risk-benefit ratio very favorable for the medications that we utilize. A new question uh, is psoriatic arthritis and rheumatoid arthritis similar in disease process? Very good question. And the answer is yeah, there are a lot of similarities. They're both what we're describing here as autoimmune inflammatory arthritis conditions. The immune system has malfunctioned. It is identifying tissues, in this case, structures of connective tissue that are surrounding or lining joints and maybe even the tendon structures, and the body's recognizing them as something wrong with them. There's something, they're damaged or they're invaded by an infection perhaps. They recognize them as something wrong with it, something that it needs to exert its forces to get rid of or damage or destroy. So psoriatic arthritis has some differences compared to rheumatoid arthritis. They both have an autoimmune driven process, as I mentioned. They both respond to almost the same medications because we're turning off the same pathways, these, as I alluded to, something called cytokines. Those are signals that the immune system would amplify to drive the immune system to cause the attacking nature that it's doing and carry out the orders. And if we can block those mechanisms, and that's why biologics are very useful in psoriasis and psoriatic arthritis. So I will make a quick distinction there. A lot more common is the entity of psoriasis, which is a thick plaque disease of the skin. Okay, that's an autoimmune disease, but it is much less common for someone to have psoriasis and have psoriatic arthritis, where there's swelling and destruction of the joints that looks a lot like rheumatoid arthritis as well. Only about 25% of people with psoriasis, plaque psoriasis of the skin, will develop also this whole body issue with psoriatic arthritis. Treatment's very much similar because there's similar mechanisms. Involvement in psoriatic arthritis can be a little bit more extensive because the spine can be involved in that disease. It's not involved in rheumatoid arthritis. With the exception of the cervical spine and the neck, there is some tissue there, that synovial tissue, lining some parts of the cervical spine, the neck area, in rheumatoid arthritis, and that can be involved. But the lumbar spine, the mid spine, there's no target tissue. There's no tissue that the body attacks in rheumatoid arthritis in those parts. So the back's not involved in rheumatoid arthritis. Okay. Here's a question. What do you do if someone is very allergic to steroids? Well, that certainly comes up sometimes, and whether it's a true allergy is always a question, but there are a lot of people who have severe intolerances or aversions to medicines like steroids. Steroids are very powerful hormones. That's what it's mimicking. Steroids, or what we use like prednisone or depomedrol or methylprednisolone, is a mimicker. It's chemically nearly identical to what you make in your body, which is called cortisol. That is a very powerful hormone. It is used in times of stress to alleviate swelling and inflammation if it's needed, but it also does a whole bunch of other things, as a lot of hormones do. It will amplify blood sugar. It'll prompt the liver to produce blood sugar, and that can raise blood sugars and cause diabetes for people who are taking long-term steroids. It also, in a person, cortisol, which is similar to steroids as we're talking about, is meant to help us in certain situations. It'll spike up at moments of stress and exert the effect that is desired in that moment, or reduce inflammation, or increase the blood sugar production by the liver, or any number of things, increase blood cell counts. Prednisone can do all those things, but it has a lot of deleterious effects when it's too high for too long. It's hard on the bones, the eyes. The blood sugar causes you to be hungry and gain weight, retain fluids. The list is just so long with steroids, but it's all dependent on the dose you're taking and how long you're taking it. In other words, doses of 5 milligrams and less are pretty negligible for those cumulative risks that I just mentioned. So that's why we're a little more cavalier with that at lower doses, but definitely not at higher doses for too long. when someone is allergic to or has aversions to steroids, it does limit us somewhat. And then we would have to rely on medications that can do what steroids do, but might take a little longer to exert their effect. And those are things like the rheumatoid arthritis therapies. They essentially will block similar inflammatory mechanisms that steroids do, only unlike a few days to work like steroids, those medicines have to exert their effect and turn off switches slowly over time, and that can take months. So those are the alternatives to steroids, and sometimes we'll use non-steroid anti-inflammatories, which are not a steroid medicine, and they have certain drawbacks too, but those can be used in place of the steroids as well. And sometimes we can't use anything, and we have to figure out other pain relieving strategies, which gets pretty extensive and very individualized as well. How is rheumatoid arthritis similar to fibromyalgia? I would say the similarities to fibromyalgia and rheumatoid arthritis is simply that there's pain. Fibromyalgia, which some people probably are aware and some are not, is not actually an autoimmune disease. It's really not a rheumatology disorder. It's just been pigeonholed into rheumatology because there's musculoskeletal pain. Our understanding of fibromyalgia is actually, it is what is called an afferent processing disorder of the central nervous system, meaning the nerves that supply information to the brain, and whether that's pain or other sensation like touch, or many other symptoms like autonomic functions, heart rhythm, and in others, in unusual sensory disturbances, are in dysregulation in fibromyalgia, and that can lead to a lot of musculoskeletal pain. There's high concentration of what are called nociceptors or pain receptors, and they're in big muscles in the shoulders, in the thighs, around the joints, where the joints get stretched, and that will stimulate those nerves normally. But in fibromyalgia, they're on a hair trigger. They're sending the information very easily with very little stimulation to the brain. It's real pain. It's not made up. It's not in your head. But it's because there's dysfunction in those nerve fibers telling the brain, hey, there's a good reason to have a high amount of pain here. Do something about it. But in actuality, there's not a good reason for the pain. It's just that the function of those nerve fibers is aberrant or dysfunctional, and it's sending that information to the brain. That can manifest in so many different ways. There's often corresponding functional problems like irritable bowel syndrome and migraines accompanying folks who struggle with fibromyalgia. It is not uncommon for people with rheumatoid arthritis to develop secondary fibromyalgia, and that's the same with a lot of autoimmune disease. Any chronic medical condition would predispose a person to develop amplified pain or fibromyalgia symptoms because there's a lot of chemical disturbances, and there's a lot of mental struggles and depression, sleep disturbance. All those things causes chemical changes that can unmask the sensitivity of those pain receptors, and that leads to fibromyalgia. It's not uncommon to see that coexisting in a lot of our patients in rheumatology with any rheumatologic disorder. But is not distinctly an autoimmune disorder that is resolved or treated with the same medicines. It's a much different approach. Okay. And there's not joint damage with fibromyalgia. There's really not musculoskeletal damage that occurs because of that. The sensation of pain is what characterizes it. How can you be sure? Here's the question. How can you be sure it's rheumatoid arthritis if you're seronegative? Well, that's a good question, and we're not always sure. But here's the thought process on that. To this day and age, we have two markers, actually three, that are excellent markers for the specific entity that we call rheumatoid arthritis. And when that corresponds with someone having typical swelling in the joints, and we're measuring high inflammation in the body by blood tests, and that we can diagnose typical or classic form of rheumatoid arthritis. About 30% of the people, though, don't have those markers, but they have the same clinical features, the same joint swelling in the same locations that would be seen in people who we can measure those blood tests. And so it looks clinically like rheumatoid arthritis. It behaves like rheumatoid arthritis. There's high inflammation in the body, and it responds to the same medicines for all intent purposes, we consider that a variant of rheumatoid arthritis. It's just a variant in which that body, that person, doesn't produce those same antibodies. There might be different antibodies, but to this day and age, we don't know every single antibody that could exist because we haven't encountered that, so we don't know how to reproduce the investigation for those antibodies to prove it. They probably do exist, but we haven't discovered that. That's why there's ongoing clinical bench research and that to discover if we could find other markers. But to your point, there are other entities that cause inflammatory arthritis that can be mimickers of rheumatoid arthritis. They still have in common that they're often inflammatory arthritises. Whether or not we call them rheumatoid arthritis certainly might be a matter of semantics and definition, but they have a lot of similar qualities, and they usually respond. If it is an inflammatory arthritis, they usually represent that the body is creating an inappropriate inflammatory response in the joints. You can have inflammatory arthritis that looks like rheumatoid arthritis, but have gout, which is a substance that gets in the joints and irritates the tissue, and then the immune system creates an inflammatory response. You can have inflammatory arthritis due to something called reactive arthritis, where you've had an exposure to an infection, and that kind of turns on the wrong switches in the body, and then you have a aberrant and incidental attack on the joints. That usually can be short-lived, though. Sometimes it's long-term, and it looks like rheumatoid arthritis, and it walks like a duck and quacks like a duck, so we treat it like a duck a lot of times is a short answer. We do always want to exclude other things. The big ones when we have inflammatory conditions is we want to make sure that wasn't stimulated by a cancer, infection, and then autoimmune disease. Those are the big three when we have inflammation of joints, and we know it's not something like osteoarthritis. We know there's an inflammatory problem going on. Those are the top three things we've tried to rule out. So good question. And it's kind of been more by default that name seronegative rheumatoid arthritis has been utilized. It's also because when we're trying to get medicines approved to treat it, which do work, the same rheumatoid arthritis medicines, in our medical climate, insurance requires a diagnosis, and that is a qualifying diagnosis in which we won't get any pushback by insurance still. And it's still not inaccurate because it looks like rheumatoid arthritis, clinical features of it. You don't have to have the markers to say that that's a diagnosis if you have enough of the objective criteria met. Okay. Well, I would love to go on and on. I love talking about all these things. I apologize if we weren't able to get to all the questions. I appreciate the participation out there. I see there are a lot of people watching, and we certainly value your interest. And again, we are OSMS. We're a physician-owned practice with orthopedic surgery and rheumatoid or rheumatologist specialist. My name is Dr. Michael Avery. I'm a board-certified internal medicine doctor as well as board-certified in rheumatology, as are my colleagues. I have 4 other rheumatologists. We will have another rheumatologist joining us in the future, projected. You can always make an appointment with us if you have suspicion that you might have something like rheumatoid arthritis or other rheumatologic disorders. We are happy to investigate that with you and go through that journey and try to answer those questions and offer some solutions if we do find that to be the case. Thank you very much.